Greetings, I'm Dr. Season2 of Yonsei University Dental Clinic. I'm honored to be here as an online master course lecturer at Ostem Implant. Today I'm going to talk about prosthesis setting. There is a defined setting process for prosthesis. This is clear. From the lab, on the model, if prosthesis is delivered, then you check the fit and then you connect stock or custom abutment. In the case of single prosthesis, provisional doesn't really matter, but in the case of multiple case, you need to set the provisional first and check whether there's cheek or tongue biting. And proximal contact of final prosthesis needs to be confirmed. If seating is done properly, then occlusal adjustment is done. After that, in the case of ER-type prosthesis or screw-type prosthesis, the screw hole filling is done. In the case of cementation type, this step is foregone. The last step is final cementation. Let's look at the order in detail. Once prosthesis comes on plaster model, you need to check whether the marginal fitness of abutment and crown is good. And the jig which you use to connect the abutment should be confirmed as well. On the plaster model, if the contact and margin does not fit well, it's not going to be good in oral cavity as well. Therefore, on the plaster model, you need to check these two factors. If it fits well on the plaster model, but because of wrong impression coping connection, or if the lab analog has been connected wrong by the lab, then there can be deviations or error when we connect it to the oral cavity. When we take impression coping, this is the wrong way. You need to make sure that the hex is correct. This jig transfers the abutment to oral cavity. You need to check whether this jig fits well. Be it custom or stock abutment, you need to make sure whether there's any gap between abutment and jig. Second, after abutment is connected using jig, you need to check whether there's a gap between the jig and adjacent tooth or not, or whether it has been properly seated. When we receive the prosthesis from the lab, then there's a jig and there's abutment for the patient. When you connect it to oral cavity, you need to check whether there's any gap between abutment and jig and whether there's gap between the jig and the stop in the adjacent tooth. Once this is confirmed, abutment can be connected nicely. Be it subgingival, equigingival, or supragingival, you need to check whether it has been correctly transferred to oral cavity. You need to check it with X-ray. This is a must. You need to check whether there's any conical gap on X-ray image and whether there's excessive space or lack of space below the hex. If it is excessive, then wrong connection is done. If there's conical gap, this is also wrong connection. With tactile sense, you can sense whether the hex has been connected correctly. If you look at X-ray, this is wrong connection and this is correct connection, and the difference is clear. In conical gap, you can see the difference and there's more gap below. You need to follow the torque recommended by the company when connecting abutment. Except for mini, regular, wide, you need to connect with 30 Newton centimeters, and for mini, you should not exceed 20 Newton centimeters. If it exceeds 20 Newton centimeters, then screw fracture can occur. Once the abutment is connected, in the case of single implant, it doesn't matter, but in the case of multiple cases, it is better to connect the provisionals. You need to look at the antagonist relations and vertical dimensions. You check that with provisional, and if the provisional is too buccally inclined or if there is edge bite, then there can be cheek biting. The definitive prosthesis follows the provisional, therefore, you need to refabricate the final prosthesis. When you have done up to provisional, now you are going to set the final prosthesis. You need to check the proximal contact first. If the proximal contact is too tough and if it is not seated properly, then you may get the misconstrued idea that the prosthesis does not fit well or that the occlusion is high. Therefore, before doing occlusal adjustment, you need to check a proximal contact. There are 3 ways to check. First, you can use the floss. Second, articulating paper, and you can use a marker to check the proximal contact. You can tell whether the contact is tight or loose with the adjacent tooth, and you can check the position and where it is in contact with the adjacent tooth. With a marker, if the area is tight, you can check where it is tight using the marker. This is the floss. You can only see the contact with this. Using the floss, you need to check whether the contact of adjacent teeth and the antagonist are tight or loose. If the contact of adjacent teeth are loose, then it doesn't matter if it is loose. However, if the contact between all the other teeth are tight and it is only loose with the prosthesis, then adjustment may be necessary. If the floss cannot go through, it is excessively tight, and if it can pass through too easily, then there is concern for food impaction. This is the marker. You can check the position. If proximal contact is too tight and if you have no idea where it needs to be adjusted, use a marker. It doesn't matter if it is gold or PFM or zirconia. Apply it and then you set it in the oral cavity. Then full seating will not be done. It doesn't matter. And if you take it out, you can see the signs of the marker where it is in contact. By adjusting the set areas, you can make the contact loose. Third is articulating paper. You can use it in oral cavity, or if you have plaster model, you can use it on there. If the articulating paper comes out loose, then the contact may be loose. If it is tight, then it will not slip through. The same as with the marker, you can see where it is in contact if you use articulating paper, and you can adjust the proximal contact area. When adjusting proximal contact, you need to make it towards the buccal and occlusal surface. If the proximal contact area is adjusted towards inferiorly, then there can be more foot impaction at the top of the prosthesis. You need to make it head towards buccal occlusal surface. These are different instances. You can only tell the level of contact tightness with floss. You cannot see the position. In the case of marker, you don't know how tight or loose it is. You can just check the position. With articulating paper, you can check both. You can utilize these tools appropriately. There are many tools that can be used for adjusting proximal contact. There are different materials preferred by different dentists, and depending on how much strength is applied and what kind of rotation is provided, proximal contact amount changes, and therefore personal experience and know-how is important. After checking the contact before setting the prosthesis, you need to check using shim stock. You need to do it before delivery. You need to check not just the adjacent teeth, but the most anterior aspect as well. You need to check using the shim stock. If you only check mesiodistally, occlusion can still occur even if the prosthesis is high. Therefore, you need to check whether the patient can bite down on the shim stock. You need to check the superior side using this. You need to check whether the patient can bite on the shim stock the same with the prosthesis on. You need to check the opposite side. After delivery, you can use the shim stock or articulating paper and check and make adjustments. You need to make sure that occlusion is done similar to the surrounding teeth and that the shim stock is bitten up to the anterior part. When connecting abutment, you need to use the torque recommended by the company, 24 milli and 30 Newton centimeter for regular, and you need to induce sinking down and connect the abutment. In order to induce a sinking down, you need to tighten and loosen 3 times. The freshly made prosthesis, there is no wear on it. The process of tightening and untightening needs to be repeated 3 times in order to induce a wear on the screw so that it can be connected properly. Or once connected, you can have the patient bite on cotton roll very hard. Then temporarily there will be sinking down, and if you tighten once again, then you can reduce sinking down significantly. If you do not do sinking down, if you do not do this several times after delivering final prosthesis, the patient may complain of inability to chew food. In the case of internal type implant, the sinking down cannot be avoided, therefore you need to tighten it repeatedly. In addition to tightening it repeatedly, you can use provisional. You can have the patient use provisional for over a month. When abutment is first connected, then there can be interference with surrounding bone. If you use provisional and apply load continuously, then this area can be resorbed and proper seating can be done. By using provisional for over a month, the sinking down can be done ahead, and on abutment level, you can take impression once again and fabricate final prosthesis. There is screw type, cement type, and ER type prosthesis. The order is the same. First is the screw type. First, you need to check the plaster model and check proximal contact, gingival contour, and then do occlusal adjustment. Unlike ER type and cementation type, there is no cementation. So those steps are more easier, but the proximal contact, when you adjust it within oral cavity, you need to tighten and loosen the screw continuously so it can be cumbersome. In the case of screw type, you need to check the contact. You need to tighten and untighten the screw. You need to look at gingival contour, and if it looks okay, then you need to tighten using the torque recommended by the company. You need to check the final prosthesis with X-ray images. You need to tighten repeatedly as shown. In the case of screw and ER type, there's hole on top. This hole is covered using either one seal from Ostem, Teflon tape, or cotton pellet. In the case of cotton pellet, at times, later it can smell, therefore, one seal or Teflon tape is recommended. On top of it, opaque resin is used to completely cover the screw hole. This is cement type. In the case of cement type, the abutment is connected with an oral cavity, and on top of it, just as trying in a natural tooth crown, prosthetic setting is done. Checking needs to be done on the model, and you need to check whether the margins are right. Abutment level impression is taken, and on the plaster model, you need to remove the abutment and jig and connect it in oral cavity and check using X-ray images. If there's wrong connection, you need to adjust it. If there's wrong connection, the final prosthesis will not go in properly. Appropriate torque is provided and proximal contact is checked. And internal fit is checked. In the case of prosthesis from lab, the fit is good in most cases, but in the pontic area, it can be too convex. If you press too hard, then the prosthetic setting will not be done properly. In that case, the pontic area needs to be adjusted. In the case of abutment screw hole, you can use one seal or Teflon tape or cotton pellet, and then do cementation. In the case of cement type, there is no hole, so you need to remove excess cement properly within oral cavity. If there is excess cement, it can lead to inflammation. This is ER type. In order to remove and prevent inflammatory responses, ER type prosthesis was introduced. It is connected with an oral cavity, and there's a hole in the prosthesis. Just as you set the natural tooth crown, you set it and then you remove the excess cement. In the case of ER type, you need to check using the plaster model first, and using jig, you connect the abutment. Before connecting the abutment, you need to check whether there is a wax or cement. You need to remove thoroughly before doing connection. Also, X-ray is used to check whether it has been properly connected or not. After proper connection, you need to check proximal contact and adjust the contact area. As for ER type, the hole itself is sealed using Teflon tape. After that, cement is using for cementation. In the case of ER type, the excess cement comes out here. Hence, excess cement comes out less towards this side, unlike the cement type prosthesis. As for cement type, the excess cement comes out this way, but in the ER type, there's a hole here and it mostly comes out here. Therefore, compared with cement type, there's less excess cement in the gingival margin. You remove the screw hole which has been sealed off. You remove the prosthesis and you thoroughly remove the residual cement. This is a benefit. And you can also remove the residual cement on the gingiva. And then using hex driver, it should be connected using the torque recommended by the company, and because the ER type has a screw hole, you need to use one seal cotton pellet or Teflon to fill the hole, and opaque resin is used to seal the hole. This is the order of ER type: abutment connection and cementation, and then removal. You remove it and remove all the residual cement and then connect it once again. This is the conclusion. In the case of screw type, abutment and crown is one body, so you can screw and unscrew. As a result, maintenance of proximal contact is made easier. In the case of cement type, it is cemented, therefore it is extremely difficult to maintain proximal contact. In order to repair it, everything needs to come out. That has led to invention of ER type. ER stands for easy removable. It can be separated as shown, and proximal contact can be adjusted. This is a major plus. Thank you. I've briefly addressed prosthetic setting online. In offline master course, you'll be able to do a hands-on practice using various materials and do prosthetic setting. I look forward to your keen interest. Thank you.